Hello friends. Welcome back. In this video I will talk about monkeypox, a mystery disease that took everybody by surprise at a time when the world was just recovering from the jolt of COVID-19. First important thing to note is that the name monkeypox is no more accepted now and WHO has renamed it as Mpox. This happened after many organizations urged WHO to rename the disease to avoid stigmatization of people affected by the disease. Also, the disease is not transmitted from monkeys to humans. The name monkeypox was given to this virus because it was first identified in monkeys in 1958. The first case among humans was detected in the year 1970. Mpox was limited to Central and West Africa in sporadic or endemic forms. In 2003, first case of Mpox was reported outside of Africa. In 2018, 5 cases were reported in a single year outside of Africa, 3 in United Kingdom, 1 in Singapore, and 1 in Israel. In 2022 the world saw a global outbreak, starting with the first case in United Kingdom, followed by cases in Portugal and Italy. In July 2022, World Health Organization declared the outbreak a public health emergency of international concern. In May 2023, the emergency status was terminated due to progress in controlling the spread of the disease. Here you can see that the Mpox cases were predominantly reported among young and middle-aged males. This paper was published by me that explained how Mpox is a DNA virus and it is close relative of smallpox. It is important to note that DNA viruses rarely cause global pandemics, and ever since smallpox was eradicated, this was the first time a DNA virus was declared a public health emergency. Both viruses when compared have some similarities, but the mortality is much lower with Mpox compared to smallpox. The vaccine prepared against smallpox is effective against Mpox, and therefore all those people who were born before 1980s were naturally immune as they were vaccinated against smallpox. This was another reason why Mpox predominantly affected the younger adults. 2022 outbreak was caused by clade 2 that was endemic to West Africa. After a peak in summer of 2022, cases of clade 2 Mpox decreased, but they continue to be reported at low levels globally. Clade 2 Mpox is less severe than clade I, and greater than 99% people survive. Some prominent features of 2022 Mpox outbreak were that it was seen predominantly in the MSM group aged 31 to 40 years. It had exclusive human-to-human transmission. The prodrome was absent and it had an unusual distribution of rash involving the genitals. Mpox is transmitted by close contact with lesions, body fluids, respiratory droplets, and even contaminated bedding. Since May 2022, total number of reported cases have been 102,220 people have died. The map shows number of cases reported globally from various regions of the world. The Mpox deaths have also been distributed globally. Now let us look at the clinical features of Mpox. Its incubation period is 13 days and varies from 3 to 34 days. Mpox may begin with a prodrome of 1 to 4 days followed by an eruptive phase lasting for 2 to 4 weeks. This is how the lesions progress through various stages of macule, papule, vesicles, pustules, and finally scabs over 2 to 4 weeks. In this picture also, you can see how the lesions progress over the weeks. Lesions often occur in the genital, anorectal areas or in the mouth, and they develop simultaneously. Rash is not always disseminated across many sites on the body and may be confined to only a few or only a single lesion. Mpox rash may involve palms and soles but does not always involve them. These few pictures show various formations and locations of Mpox lesions. Mpox lesions are described as firm or rubbery, well circumscribed, deep-seated, and often develop umbilication. Patients may have rectal symptoms in the form of purulent or bloody stools, rectal pain or bleeding. Lesions are often described as painful until the healing phase, when they become itchy and develop crusts. They may have respiratory symptoms sore like sore throat, nasal congestion, or cough. The lesions may get complicated and develop pitting scars on face, infected skin lesions, corneal ulcerations resulting in vision loss, and bronchopneumonia. Let us look at case definitions that include epidemiological criteria, suspect case, probable case, and confirmed case definitions. First is a suspect case, that is defined as a case with a new characteristic rash, or meets one of the epidemiological criteria and has high clinical suspicion for monkeypox. A probable case in the one having no suspicion of other recent orthopox virus exposure like vaccinia virus in Occam 2000 vaccination, and Demonstration of the presence of orthopox virus DNA by PCR of a clinical specimen. Or orthopox virus using immunohistochemical or EM testing methods. Or demonstration of detectable levels of anti-orthopox virus IM antibody during the period of 4 to 56 days after rash onset. A confirmed case is defined as demonstration of the presence of monkeypox virus DNA by PCR testing or next-generation sequencing of a clinical specimen. Or isolation of monkeypox virus in culture from a clinical specimen. And finally, the epidemiological criteria include within 21 days of illness onset, reports having contact with a person with a similar appearing rash or confirmed or probable monkeypox, or had close or intimate in-person contact with individuals in a social network experiencing monkeypox activity, or traveled outside the U.S. to a country with confirmed cases of monkeypox or where monkeypox virus is endemic, or had contact with a dead or live wild animal or exotic pet that is an African endemic species or used a product derived from such animals like game meat, creams, lotions, or powders. Now, let us cover the steps of sampling from a suspected lesion. First, wear appropriate persona protective equipment and use sterile synthetic swabs for specimen collection. Do not use cotton swabs, do not perform unroofing or aspiration of lesions. Take swabs of lesion surface, exudate, and crusts. Collect 2 swabs from each lesion and collect from different sites and different types of lesions. Put each swab in a separate tube. Both dry swabs and swabs in viral transport medium are acceptable. How to label specimens. Dimension site of lesion, store in sterile leak-proof containers. Dry swabs stored at 2 to 8 degrees Celsius can be tested within 7 days. Swabs in viral transport medium or crusts can be stored at -20 degrees Celsius for up to 30 days. Dry swabs stored at -20 degrees Celsius can be tested up to 60 days. The treatment involves supportive care and pain management that is sufficient for most people. Severe illness can be seen in people with comorbidities and weak immunity. They can present with hemorrhagic disease, confluent rash, sepsis and encephalitis. Some special groups include pediatric, pregnant, immunocompromised, and people with other skin lesions. These is no specific treatment approved by FDA. The drugs approved for smallpox are being used like tecovirimat, cidofovir, brincidofovir, and vaccinia immune globulin intravenous. For pregnant females, tecovirimat is the first-line drug. Cidofovir, brincidofovir are the drugs to be avoided in the first trimester in breastfeeding. Mpox can be prevented through vaccination. ACOM 2000 or Jynneos are 2 vaccines being used with 85% efficacy. Both are used for pre-exposure prophylaxis and can be used within 4 days of exposure for post-exposure vaccination. ACOM 2000 is a live vaccinia virus preparation that replicates when inoculated into the skin by pricking the skin surface. It multiplies and can spread to other people. People are considered vaccinated after 28 days. Jynneos is a non-replicating live virus and is given by 2 subcutaneous injections 4 weeks apart. People are considered vaccinated 2 weeks after second dose and a total of 6 weeks. So, this was all about Mpox. Hope you liked the video. Like, subscribe, comment and share with your friends. Do not forget to press the bell icon to get notification of all new videos. Thank you for watching.